Okay.
Okay, are we ready to go ahead and get started? Yes. Okay. Well, today we have a very special guest with us, Dr. Henny Visser, PhD. She is a psychotherapist and CBT supervisor since 2005, working in a specialized clinic for patients with complex anxiety disorders and obsessive compulsive disorders in the Netherlands. She brought IBA to the Netherlands, wrote her thesis on the inference-based approach to treat OCD, and is currently principal investigator of a multi-center study examining the effectiveness and neurobiological working mechanisms of IBA. She is head of the Anxiety and OCD Research of her Mental Health Institute. So Dr. Visser, please go ahead and share your screen.
Thank you, and thank you for inviting me. I'm really happy to present what we're doing in the Netherlands. And before I start sharing my screen, I think it's nice to tell you a bit about my visit to Montreal back in 2008, where Frederick was already there, and also Kieran O'Connor and Marie-Claude Pélissier, and they really warmly welcomed me and learned me so much about IBA. In the Netherlands, we still say IBA. So I was really inspired and started immediate back home with a pilot study. And then after I got some funding, we did the first RCT. And this is the point where I want to start sharing my screen. Because what I would like to do is to first present some about the study that we already did, and after that I would like to present something about the study we're doing right now, and then I'll present the way we do it in the Netherlands by presenting the steps and some cases. And please interrupt me if you want to join the conversation or ask a question in between. So the first RCT that we did was with 90 persons with OCD with poor insight. So I'll tell a bit more about poor insight on the next slide, but we wanted to know whether IBA is more effective than CBT in treating patients with OCD with poor insight. And back then, we had a protocol of 24 sessions. I think, Fred, that's from Beyond Reasonable Doubt, isn't it? Well, I don't know. Anyway, we had a protocol with 24 sessions. And people were randomized over IBA or CBT, and we measured severity of OCD symptoms pre, mid, post, and after follow-up of 3 months after post-treatment. And here you can see how the assignment to the both treatments went. As I said, we wanted to know how effective IBA is among patients with poor insight. And I think you know a bit about poor insight. Patients with poor insight are quite convinced that their obsessions are true. They don't recognize that it's don't recognize completely that they are convinced about something because of their OCD, and they can't explain their conviction differently. And when someone else has another idea about that topic, then they assume that the other person is not very well informed. And because IBA focuses on reality testing, to us it seemed quite logical. We were convinced that we would find that IBA was superior to CBT. And this is what we found. completely similar results for patients who were treated with CBT as for patients who were treated with I-CBT. And that held for OCD severity, for insight, for severity of depressive symptoms, and also for quality of life. So we were confused, completely confused. And at the end of the study, there was no information about what score on a measure that measures insight, the overvalued ideation scale, that's what we used, that there was a cutoff above which you can really speak about poor insight. So we did a post hoc analysis, and of the 90 participants, how many? 23 scored above this cutoff score, and then we see that IBA was more effective than CBT. But with a post hoc analysis, you're not too sure that this is really what there is. So we want to do another study.
Dr. Visser,
Real quick, we've got 2 questions. Go ahead,
Okay.
Mary.
I was just going to ask, can you just say a little bit about the CBT? Was the CBT including exposure and response prevention, or was it more like cognitive-based CBT?
It was both, with an accent on exposure with response prevention. So in the Netherlands, that's the main way of treating OCD. CBT means start with ERP and add cognitive interventions to that. So that's.
And one other question was, is 24 sessions protocol?
That was protocol by then, yeah.
Yeah, I just have to say, like, I mean, I think it was using the worksheets and the treatment manual at the time from the book Beyond Reasonable Doubt.
Yeah.
And 24 sessions. There's no such thing as a 24 sessions protocol. It's about going through all the worksheets, and the time that you have to go through all the worksheets is 24 sessions. That's
Yeah.
It's up to the
and
therapist.
yeah, indeed.
Thank you.
And we wanted, of course, to have the same amount of sessions in both conditions. Now we're busy with the next study. Oh, sorry, I forgot the conclusions. So we found IBA is not more effective than CBT for patients with poor insight, but patients with poor insight do improve from psychotherapy. And IBA seems to be more promising than CBT for patients with the worst insight. And since it doesn't provoke anxiety, it might be an alternative for patients who refuse or drop out. So, to our opinion, IBA is a promising new psychotherapy for OCD. And we went on with a next study, and that's going on right now. And this is the research team. On this page, you see all researchers, but we also work together with persons with lived-in experience in OCD, and they help us to communicate effectively about the study. They take care that the study is not too is patient friendly, etc. And with one of them, I wrote a Dutch book on treatment of OCD, in which also the protocol of I-CBT. So this is Maartje Punt in good Dutch. And with her, it was a great joy to write a book together with someone with OCD on OCD. So that's a great experience for me. This is what we do. you see a picture of the Netherlands over here, and all healthcare institutions throughout the country working together with a university in Amsterdam. And now we want to know whether IBA is non-inferior to CBT in treating patients with OCD in general. That is, does IBA result in similar symptom reduction on the Y box? And I think you all know the Y box, don't you? Yeah. And except this primary objective, we've got some secondary objectives, namely, are there different changes in neural networks? So is there a different brain response after treatment with I-CBT than after treatment with CBT? And is this related to symptom reductions and changes in cognitive performances? And I'll tell some more about that in a second. Also, we want to know, do pre-treatment neural network patterns predict who will respond on therapy, and maybe even who will respond to I-CBT and who to CBT. And now we start a priori to check whether IBA is indeed superior to CBT in treating patients with poor insight. That is to say, patients scoring higher than 6 on the OVIS, on the overvalued IDs scale. Also, we want to know if it's more tolerable than CBT for patients with OCD, and what are clinical and demographic predictors of treatment outcome. And we want to know what changes first. Is that the insight, or is it the severity of symptoms? So we're also looking at that. And this is how we do it. Patients, after they have their baseline measurements, a subgroup has also an fMRI and some cognitive tasks. You can see on the right of this slide. After 10 sessions and after 20 sessions, there are interviews, scoring severity and other aspects. But also every week, patients fill in a self-report Y box and OVIS. So after, when we're ready, we've got absolutely rich data on the course of the OCD severity and insight. Well, here you see in and exclusion criteria for this study, and we recruited 203 participants, and we expect our results at the end about a year, also the follow-up measurements. Are there any questions on this research? Because if not, then I'm going to the treatment model.
We do have a question in the chat. Is there detail available about differences in successes based on subtypes from Y-box?
We don't have that yet because our previous trial was too small for that, but it's one of the factors we're looking at in this study. There are some more details on this study, but I've got it down in the presentation because I'm not sure how much everybody is interested in research. So if there are more questions, I can answer it, but we're going to look at that, yes. But we don't know yet. Do you know, Fred, did you look at subtypes?
Well, yeah, I can add some more to it. I mean, when we're talking about subtypes, we're talking about discrete categories of people with predominantly checking, predominantly contamination. That's analysis that's hard to do statistically because you need large groups. What we do have information about and we are going to look at that, and so is Henny, as he was saying. Once we have a large group of people, and we are classifying people according to subtype to the extent that that's possible to start with. Usually people have multiple subtypes, but what we do have information on is what we call symptom dimensions of OCD, which is questionnaires that measure severity of symptoms within specific symptom dimensions, which is checking, contamination, the unacceptable thoughts category, just right, etc. That's what we do have data on, and the interesting thing about I-CBT is that it seems to work across the board. I mean, it reduces symptoms across symptom dimensions when you measure it, perhaps more so than some other treatments. That's what we did find in our last trial. So the general conclusion of that is that I-CBT seems to generalize well across symptom dimensions, which is a similar concept as to subtypes. So we haven't looked at yet at particular specific subgroups, but symptom dimensions, yes.
Good. Well, I think everybody in the chat now is familiar with the basic assumptions of IBA. Still, I think it's good to repeat. IBA teaches patients how to defend against the absorption and confusion effect of obsessive reasoning, how to stay in touch with reality by actively relying on the sensory information. This is a picture of the vicious circle we talk about in the Netherlands. And I'm quite sure it's also quite familiar to you. But when we present about I-CBT, we always start with patients with OCD get stuck because they try to solve an imagined problem in reality. And solving an imagined problem by doing something in reality is impossible, and it's the consequence of doing it is that the border between reality and imagination blurs. So imagination feels real, and that's why people get confused more and more, and that's why they want to be better safe than sorry. And I think we come back to that when it comes to tolerating uncertainty. I think with IBA treatment, you don't have to tolerate uncertainty, and that's what you want patients to discover. There is no uncertainty to tolerate, there is certainty. So that's what we're working on in the treatment. But if you keep on doing something in reality in reaction to an imagined problem, you get all tied up. And this is how Maartje Punt, the one I wrote the book with, illustrates getting tied up. So this is a Dutch picture. You can't read this, but why I show it to you is because you can see the cycle, 2 steps of treatment. I'll explain about them in a second. You only do once, and then for each compulsion you treat. The steps 3 through 8 are taken, and the last step, or the last 2 steps, the vulnerable self-theme and relapse prevention, also you don't repeat those steps. And in this picture, the vulnerable self theme is one of the last steps, but I think you also sometimes do that earlier. About those steps. In the first step, it's the first several steps, it's all about recognition. So recognize the whole OCD is about doubt, and that the doubt is fueled by a story about possibilities. And then, and I'm curious about your reactions to that. In the third step, a story in which the inner senses and so an alternative story, of course, you also make an alternative story. But in the Netherlands, this alternative story is a quite central part of the treatment, and we do it early in treatment. So maybe there's already someone want to react on that or have a question about that.
Well, there is a question about that infographic that you showed. People are asking if we can get copies of your slides when you're completed.
Yeah, no problem.
Wonderful.
They are in Dutch, but this infographic was in Dutch, but sure, no problem.
I think the first one where the cycle of OCD you had outlined.
Oh, of
Very
course.
good.
Yes. Okay. Yeah, sure. Sure. No
Yeah.
problem. Yeah. Well, and then the next step after that alternative story is recognizing that the doubt arises from the imagination, and then that the doubt is irrelevant for the here and now. In the case I'll present, we come back to that. And then after all that recognizing, it comes to a skill, the skill of shifting attention to observable reality. So step 6, I think it all has different names in Canada and America, but here it's I call it a skill now, and I think this set shifting, attention shifting is also something I hope we're going to see on those neurocognitive tasks and on the fMRI, maybe, because I think that's what one of the working mechanisms of OCD, being able to shift attention from imagination to reality.
Henny, can I just interject something? So in terms of your first question, like whether in the Netherlands very early on you start with the narrative, and how would that compare to how it's done here? I think it varies. I think somebody in the chat said the same thing. It varies. One thing I've noticed that in North America, people are a little bit more uncomfortable with alternative narratives because they're very worried about reassurance seeking, like when is an alternative narrative compulsive and when it is not, you know. That's one of the things. I think in general, when it comes to the modules, it's fairly laid on into the modules of the new treatment manual, but it doesn't mean that you cannot address it earlier. It depends a little bit on the patient and the circumstances.
Yeah.
But I think in general, it varies here. And you say in the Netherlands, we do it early on. What is your experience with the alternative narrative being used as a compulsive activity? Is that a problem you encounter?
Oh, you always have to be in Dutch. Je moet er goed op letten, Fred.
Okay.
Huh?
You have to watch it. Yeah. So
yeah, really, because that is possible, and people treat their treatment sometimes compulsively. So that you have to watch that. But maybe I'll show you an alternative narrative in a few seconds, and let's come back to it then, because maybe by being so explicitly focused on how do you determine it in a neutral situation. So that's the accent in the alternative narrative. But let's see when we come to that, okay?
Yeah.
Yeah. Well, and then of course the OCD reasoning tricks, recognize them and comprehend what they're doing with you and reject them. That's a skill people have to train and learn. And then, or earlier, if necessary, recognize obsessive self and build on positive realistic self. And of course, relapse prevention. So here's the same picture again. That's because of the order. Let's talk about Fida. I call her Fida. She's 35 years old, married, mother of 2 kids, and she's an economist. And for a long time, she suffers from fear of contamination. And because of that, she washes her hands a lot, cleaning doorknobs, etc., of course. And that's not only because she thinks it's disgusting, but also because she's really scared people might get ill. And beside that, she's afraid that she, without noticing, causes a traffic accident. And because of that, she drives back a lot, takes a lot of time. Here you see a part of her case conceptualization, and we started with her compulsion. It's in my dinges, it's yes, hand washing. I had to remove you a bit on my screen. So she washes her hands a lot after having touched toys of the kids, and she wanted to start with this compulsion because it takes a lot of time, it happens a lot, and it is a compulsion which doesn't scare her too much not to do it. And you can see in the next OCD chain is that we Fred met opzet. Purposely, yeah. We purposely defined this as extra careful hand washing, because hand washing after pooping is normal behavior, but the compulsion is the extra careful hand washing. But about this hand washing after having touched her kids' toys, she does that because she's specifically afraid of being contaminated by the E. coli bacteria. And this is what we always do. I think you too, but when somebody washes hands because of contamination fear, I want to know, what dirt are you afraid of? So not just my hands might be dirty, but there might be the E. coli bacteria on my hands. She can tell how come. So maybe you can read this. Oh, one back. She knows a lot about the E. coli bacteria. She has read all there is to read about this bacteria. And so she knows there are about 200 different species, E. coli species, that produces this poisonous stuff causing harmful effects in the human body. And she, of course, knows that doctors warn that personal hygiene is of utmost importance to prevent spreading of diseases. And she has read a lot about that. The E. coli bacteria survives months outside of the body. So if it is somewhere, it stays there. And people, adults and kids at daycare probably don't wash their hands properly, touch things that my kids touch afterwards. That's how they bring it home. So this is why for her it is quite reasonable that having touched the toys of their kids, her kids, also means that her hands now must be contaminated with the E. coli bacteria. Is there any question about this obsessive narrative? I think it's
There
quite...
are a few questions.
Mhm.
One specifically, I think addressing this narrative is, does she also make her hand or her kids wash their hands too often as well? So is she having the family compulse in the same way?
She does. So in fact, we mostly start with that. So for this presentation, I didn't focus too much on that. But when, yes, she does, and many patients, of course, with these fears do. And I always want myself and my colleagues to first address that kind of compulsions. And we in Holland, we say put an hek, Fred, een hekje, zet een hekje om het kind. How would you...
Put a fence
Huh?
around. Put a
Put a
fence.
fence around her.
Yeah, put a fence around, and also ask the father in this case to take care of that. So wash as much you want to wash, but put a fence around the kid. That's what we do. But yes.
Great. One other question, it may be a bit off topic, so we can bring this up later, but I'll throw it out there. Question, do you mix I-CBT and ERP? If you do, how? And I understand the general rule of thumb is to start with one and then evaluate if the other is needed. Is this your experience?
Yeah, one at a time, preferably. Sometimes when I'm treating patients with I-CBT and people are so very automatically doing their compulsions, I do combine with response prevention, but preferably one treatment at a time. And in the Netherlands, Fred and I chatted already a bit about it, we only offer I-CBT to patients that have already had CBT.
Yeah, so it's actually more the other way around. Usually you do I-CBT after the ERP has failed, right? And
yeah, that's what I meant. That's what I meant. So after, yeah, but sometimes you still also, when patients have already failed on exposure with response prevention, but you're a long way in your I-CBT, you can bring some exposure with response prevention back, but mostly I don't. Mostly I just work only with I-CBT when treating with I-CBT.
Yeah, the question also comes from here in North America. Is the ERP has a very central sort of like role.
Mm-hmm.
So it's hard sometimes to imagine that you do things without ERP. But no, I-CBT has been validated on its own without ERP. There's no deliberate exposure in I-CBT, nor is there deliberate response prevention in I-CBT. So so yes, it's not automatically that you reevaluate and then go to ERP. No, reality sensing is often enough, you know. And that's fine. But can you, if the question is, can you combine ERP and I-CBT? Yes, in principle. You know, we've done it in case series and case studies, but it's the treatment itself is validated as a standalone treatment without ERP.
Yeah, completely agree with Fred on this. So Okay, but this is her narrative, and I think, like you, we always, when people tell their narrative, validate that. Yes, true. Oh, I understand, and that's true. What you've been reading, it's valid information, and it's true. It is possible. And I understand that this convinces you, but tell me, is there something, some contaminator that is even dangerous, that, on which you don't have an obsession? So I always ask patients to come up with neutral examples. And in Fida's case, this is salmonella. She is not at all afraid about salmonella. Of course, she doesn't want to get contaminated with salmonella. And she takes care that she well, does the things you have to do not to get contaminated with salmonella, but that's it, nothing extra. So the alternative story is partly on salmonella, as you can see. It's a long story, but let us read it. When I prepare chicken breasts, I cut it into pieces and sweep it into the pan with the knife. After that, I put the cutting board in the dishwasher and I wash the knife. Also, I wash my hands with soap, just shortly. I feel that the pieces of chicken and the slippery and greasy layer washes away. If I don't feel anything anymore, I determine that my hands are clean. I don't worry about how a salmonella bacteria via might get to my hands. I'm guided by what I see, feel, and smell, and by what my common sense tells me. Also, when buying chicken, no need for hand washing afterwards if the package doesn't leak. If there's nothing, there is nothing. I know that you have to wash your hands after preparing chicken. That's what I do, and I know it's enough. I realize that my common knowledge on how to handle raw chicken is sufficient. Same holds for COVID-19. I don't want to get that because I'm obese. The measures imposed by the government are leading for me, and I feel inside that I'm a wise person who can determine when I've done enough to prevent contamination with COVID-19. With the same inner wisdom, common sense, common knowledge, I can determine when I should and when I don't have to take measure to prevent contamination by the E. coli bacteria. Is this like your alternative story, or are there big differences?
I really like the example, and I think it raises a good point, is how you try to create an authentic alternative story that doesn't so much tries to negate the obsessional story, but you're sort of like mobilizing the healthy reasoning that already exists in very comparable situations, but where the reasoning is entirely different. So you mobilize the healthy reasoning there. And I think it's a good way to do an alternative story, but first looking at a neutral situation.
Yeah.
And bringing that in, then automatically you can ask the question, like, why don't you apply that to the obsessional situation as well, right? Or the same criteria, the same story should apply to the obsessional situation, all things being equal, right?
Yeah.
Yeah, I really like it. In a sense, I've always said, like, the obsessional story or the alternative story needs to stand on its own. And I think by bringing in a neutral story first, or a neutral element first, you make that even stronger, you know, consider more authentic. So
I think this is one of the evolving elements, and I think we can see Marie-Claude Pélichet's influence over here. This is what we did a lot in the Netherlands. And of course, starting with what is the opposite of the primary obsession. So the title is There Might Be E. coli bacteria on my hands. In the obsessive story and in the alternative story, my hands are clean. And then how do you determine that your hands are clean when it comes to a neutral situation? And what we hope and what we work towards is that people make contact with, oh yeah, I know, I can determine, I know, my senses are perfectly okay, they work. So, and also we want people to feel, oh, in the obsessive situation, my basis is what is possible. And in all the other situations, my basis is automatically what I sense and what I know inside my common sense.
Mm-hmm. Yeah, I think this obviously this goes back to the selectivity of the OCD, but it's very important. It's so essential and such a central part of I-CBT, and so important to realize that OCD is not the same as an anxiety disorder.
Exactly.
Yeah, if a person fears contamination, it's not just a general fear of contamination. It's often quite specific about something. In this case, not salmonella. You don't see that in other anxiety disorders. A person has sociophobia, they are phobic generally in all social situations, not in one particular person that looks a certain way. No, it cuts across. With OCD, you don't have that. Same as a person with spider phobia. They're usually afraid of all spiders, not one particular species of spiders, right? It cuts across. With OCD, you don't have that. You have the selectivity. This goes back to like there's something more going on than just the generalized worry or anxiety as you see in anxiety disorders. They categorize, people with OCD categorize things differently, apply one story, an obsessional story, to one situation, but absolutely not to a comparable situation. And you can, and using that is very helpful in treatment.
Yeah, we use that a lot, and we use it specifically to make people feel and recognize, oh, there's no uncertainty to tolerate, because in all comparable situations, if you ask me, are you certain? Yes, I am certain. There is certainty also about an invisible contaminator. I'm certain. I'm certain that there's nothing indicating that I should take some extra measures.
How much question? How do people react to that in the Netherlands? Where you say, like, meaning other psychologists, other researchers who are in the CBT model, when you say like it's not about intolerance to uncertainty and that you can have certainty, does that meet with a lot of resistance?
Now, depends. When there's a presentation like this, and we illustrate step by step, this is how I-CBT helps the patient recognize, well, there's nothing, there's only a possibility. And these possibilities pop up in my mind in an irrelevant context, especially this irrelevant context. Mostly the question doesn't come, but I like to highlight it, that there is certainty. Yeah.
So is that a really important element about in standard CBT or standard whatever appraisal-based CBT, where you cover all the different domains, right? Is there any particular domain that's considered more important than the other in Europe or in the Netherlands? When you like responsibility, perfectionism, and you cover all these in standard CBT?
No, no, I think there are some groups working with metacognitions, of course. But in general, the accent is on exposure with response prevention and some, I think, a chance calculation is popular, and also the pie, you know, the pie. Who's responsible? Who else is all responsible? But I see the time is ticking, clock is ticking, so I'll go on with the fourth step.
All right.
And in this order, so after the obsessive story and the alternative story, which people read several times a day on a non-obsessive moment, then we come to the next step. And then we do in the session an exercise when it comes to someone washing hands because of contamination fear. We tell them, listen, another person washes hands because of the doubt his hands might be contaminated after someone beside him sneezed and he felt drops landing on his hand. Tell me, last time you started washing because you supposed that your hands might be contaminated. How did that start? Was there some kind of sneezing event first, as in this example? So people try to find out, okay, it always starts with popping up possibilities and without an proving event. And then
before you move forward, there's a question on the previous slide that I missed, if you don't mind just a moment.
No problem.
And I want to make sure I'm asking it correctly. So the neutral situation is somewhat close to the client's obsessional situation, which is very interesting. Of course, OCD can grab that too. Do you find that that happens, that an original neutral situation is then grabbed by the OCD?
It's so funny because I thought, where does the question stay? when does this question come? Because this is a question always pops up. It never happens. What does happen is that, and that's very, very seldom.
Rare, very rare.
Rare, yeah, that's very rare. But what does happen is that people start compulsively ask themselves, do I doubt on this now too? So they're compulsing on their treatment, but the neutral example used in the alternative story never gets the new obsessive topic. Never happens. And I'm not too surprised by that, because OCD determines which topic will be picked. So someone's obsessive story makes a topic obsessive. And in the neutral story, there's reality sensing. So the normal basis is highlighted to compare with the obsessive story, but there's no obsessive story about this neutral subject. Although we do that in the fifth step, and I think you do so too. Namely, after this, what I presented about the imaginary basis of the doubt, we come up with the relevance of the doubt. And then we do a lot of, in the session, a lot of examples at the very moment. Are you worried about the roof coming down? no, why not? Roofs do come down sometimes. Didn't you read the news? But okay, you're not worried right now. What has to happen first to make you consider that or how roofs can come down? So we're highlighting the irrelevance of the doubt and the fact that normally people dismiss possibilities when there's nothing here and now telling that the problem is actually there. And in this step, and this is what I meant, we sometimes ask patients to make a neutral example obsessive. For example, crossing the street, make up a story, make up an obsessive story about crossing the street. And I don't know what your experience is, but it never happens that after that exercise, people start compulsing about crossing the street. Do you ever experience that?
I have not seen it, no, unless they already had obsessions about it. But...
yeah. But I think this also is a powerful step. Well, and then this is a Dutch slide again, but I copied it, but I think you recognize this is the crossing over point. We always draw the world of the senses and the world of the imagination, and that there is a bridge in between. And when you succeed in holding before the blue point, then there is a way back. And when you go through via the red route, you're sucked up and there's no way getting back. So people practice to find the moment on which there is a way back, and then ask themselves, so in Hafida's voorbeeld, before starting to wash her hands after having touched toys of her kids, she asks herself, is there anything here and now that justifies hand washing? What do my senses tell me? What does reality tell me? And what does OCD tell me? And what do I want to choose for? I think you recognize this.
I was just going to say, here's a place to interject another question.
Yeah.
I think it makes sense. It says, I explain to my clients that there is certainty and that there is nothing in their base, nothing here and now information, but certainty about the feared outcome. I'm not reading this correctly. Let me try again.
Yeah.
I explained to my clients that there is certainty in that there is nothing there based on the here and now information, but not certainty about the feared outcome happening. Is that correct?
I don't do it myself, but I don't think it's not correct. So yeah, you can say that there's no certainty about the feared outcome, and that's true. Of course, that's true, because there never is. The obsessional doubt only occurs in a situation in which it's observable that there's nothing wrong. So there is never proof and certainty about the feared outcome. That's true. That's true. I don't highlight that myself that much, but it is true. What I do is compare a lot with other people's obsessions. Because if patients, they can look from a distance to the reasoning process and obsessions and compulsions of other people, because that's not their obsession. And I compare it a lot. The most used example is the doorknob for patients fearing that they didn't lock their door. When you put the doorknob down and you pull it backwards and it doesn't open, if this is your obsession, you can keep on doubting that it is locked. And for patients with other obsessions, it's so clear, oh yeah, the doubt is there, completely contrary to what you can see and feel and hear at that very moment. Once again, looking at the clock, I've got another case and I like that case, so I want to present it to you. But Fida's problem was that she wanted to choose for reality. So she didn't go into this exercise by really looking what is there any justification of hand washing, but she wanted not to hand wash. So she couldn't really rely on her senses or inner knowledge about the relevance of hand washing after touching kids' toys. And this happens a lot, especially when patients already have been treated with exposure with response prevention. And what I do is I tell her, you know what, try this exercise knowing that you are going to wash your hands no matter what in a few minutes. So you're gonna do your compulsion, but still, before you do it, take a little time. Is it necessary? Are you going to do it for nothing, or is it reasonable? So then the pressure of I'm not allowed to do my compulsion can be lowered a bit. And after such experiencing that, then this exercise can be done without this extra step. Maybe I'll dismiss this because I think it's quite familiar. And then about Fida, we worked through in the same way other contamination obsessions. And when we came to her driving back because of her uncertainty that she might have hit someone in the traffic, she needed an extra story and a narrative about how it could be that she didn't notice hitting someone in the traffic, and an alternative story in which the neutral example is driving a supermarket shopping cart, because she realizes that with the same eyes, ears, touch with which she can determine that she doesn't hit someone in the supermarket, she can determine that she doesn't hit someone in the traffic. So you see here the same way of using a neutral example to realize, hey, my capability to determine what is the case is perfectly in order. I skip her vulnerable self-team. You can see the slides afterwards. And then Jeroen. Jeroen is 42 years old and he has a 1-year-old son. Jip is his name. I called him Jip and I called him Jeroen. And he's a veterinarian. Now, I don't know how to say this.
Veterinarian.
Okay. Previously, he worried a lot about prescribing wrong doses of meds for animals. And that's now not his biggest problem. His biggest problem is now I might touch Jip with a sexual intent. And I'm afraid of having pedosexual tendencies. And I wanted to share his narrative and alternative narrative because you can see how the same way of using a neutral example folds out in this case. His narrative about touching his son with a sexual intent is when you don't want to be something, you suppress your real self. I find pedosexual behavior the worst thing on earth, so it might be that I don't recognize my own tendencies. I easily get sexually aroused, and it happens that just looking at someone is enough to get sexual feelings, also for persons that didn't arouse me previously. What if I only notice these feelings for Jip when they are already present? It convinces him that it is possible. So he is very careful and spastic when he has to touch his son, especially when he has to give him a clean diaper. So he avoids a lot. And when he doesn't avoid, he's absolutely extremely anxious. Also, to him, I asked him, what is something, this is about inner knowledge. Are there other inner feelings on which you don't have any obsessions? And he said, well, I know what I want and what I do. I don't feel sexually attracted to animals. I can feel that inside. There's nothing indicating that I have that sexual interest. Often I'm alone with a cat or a dog. Those animals have a soft coat, and I love animals. When I have to take care of them, I stroke their coat to comfort them, and sometimes because they move me or because I feel like touching a soft coat. I can determine that there are different kinds of stroking. I noticed that stroking the soft skin of my girlfriend with a sexual intent, or with something that at first was not, but gradually becomes a sexual intent, is something else than stroking a cat's pleasant soft coat. My ability to determine whether or not I touch an animal or my girlfriend with a sexual intent is perfectly fine. With the same ability, I can determine with which intent I touch Jip. Are there any questions or suggestions about this alternative narrative? No questions? Then,
I don't see anything.
no, and I see it's 8 o'clock in the meanwhile, so maybe we'll leave it about here, or are there some last things to be said?
Great response in the chat for your presentation. People are very interested in your slides, so if you're willing to share those, that would be wonderful.
Sure.
Fred, do you have any parting remarks?
Yes, no, great presentation. It was really interesting, and it's so nice to have different perspectives, you know, from people. And we also find it in the group that everybody is making OCD making I-CBT their own in a different way, and all these multiple perspectives add to it. And then you come from a perspective that comes from a whole different continent, right? So that especially gives additional richness to the approach, which I like, you know. So I think it's too bad that there's so much to say.
Time's up, eh? It's too bad that time's up.
It's also a good reason to come back, and if you're available and some other time, and have an even deeper conversation about this, you know. So we're happy that you were here today and willing to share your experience with I-CBT with us.
Well, seems nice to me. It would be great.
All right.
So, Mary, we will have contact about the recording, etc.